The mechanism of action of desmopressin and its clinical application in the management of central diabetes insipidus will be reviewed in this video. Arginine vasopressin, AVP, is synthesized in the nuclei of paired neurons, originating from supraoptic and paraventricular nuclei of the hypothalamus and terminating in the posterior pituitary gland. The osmolarity sensing center, located in the hypothalamus, regulates the release of AVP via relay neurons projecting to the cell bodies of the supraoptic and paraventricular nuclei. There is a linear relationship between plasma osmolarity and plasma AVP levels, such that significant increases in plasma osmolarity cause a corresponding increase in plasma AVP. In the setting of dehydration, AVP, also known as antidiuretic hormone, increases water conservation at the level of the renal collecting duct, a process that increases urine osmolarity and leads to the restoration of normal plasma osmolarity. So what is the mechanism of action of AVP in normal physiology? AVP binds to G protein-coupled V2 receptors on the basolateral membrane of the principal cell. This initiates a cascade of intracellular processes involving adenylyl cyclase-mediated cyclic AMP production and subsequent activation of protein kinase A. Afterwards, protein kinase A will promote the liberation of aquaporins from endocytic vesicles. Aquaporin 2 release from vesicles inserts into the apical membrane of the collecting duct. This promotes the translocation of free water from the collecting duct into the cytoplasm of the principal cell. Next, aquaporin 3 and aquaporin 4 water channels then facilitate the final transfer of water from the cytoplasm to the peritubular capillaries. Desmopressin is an analog of endogenous arginine vasopressin, AVP, with a prolonged plasma half-life of approximately 55 minutes. Comparatively, endogenous AVP has a half-life of 5 to 10 minutes. It is worth noting that the substitution of D-arginine for L-arginine at position number 8 of the AVP amino acid chain eliminates the vasopressor effects of the synthetic analog of AVP. Ultimately, desmopressin, being an analog of endogenous AVP, promotes water conservation by binding to V2 receptors in renal collecting ducts. Finally, we will review some essential practice pearls. Desmopressin can be administered safely through various routes, including intravenous, subcutaneous, oral, intranasal, and intramuscular routes of administration. A simple rule of thumb is to use a conversion factor of 1:10 when converting between routes of administration. Co-administration of NSAIDs and desmopressin can lead to life-threatening hyponatremia in patients with diabetes insipidus. This is because in normal physiology, prostaglandin E2 impairs the liberation of AQP2 from the endocytic vesicles after AVP to V2 receptor interaction. Cyclooxygenase inhibitors such as NSAIDs impair the synthesis of prostaglandin E2, thus increasing the availability of aquaporin 2. This then leads to water intoxication and significant dilutional hyponatremia. It is also worth noting that gastrointestinal peptidases denature oral desmopressin. As such, patients should be counseled on the importance of taking this medication either on an empty stomach or at least 90 minutes after a meal. Finally, pituitary adenomas seldom present with central diabetes insipidus. For this reason, in patients with acellular mass, an alternative cause of diabetes insipidus such as craniopharyngiomas or a granulomatous process should be considered. Join us next time as we unravel more fascinating aspects of endocrinology. Don't forget to like, share, and subscribe. Until then, stay curious and keep learning.